two candidates that going for that case, just roughly just introduce your name. Okay.
My name is Yasmin from Cairo, Egypt.
Okay. Hi.
Yasmin
Nice
Zakaria.
meeting. Yeah. Okay. And Yasmin, you are the first for the first case, and who will join Yasmin for this case?
Sir, I'm Akshya from India.
Okay.
I would like to join her, sir.
Okay.
First
Okay.
case.
So we got two, and yeah. And for the second case?
Sir, I will join. Dr. Faiza, I will join for the second case.
Okay, Faiza will take first part of the second case, and the second part? Anyone for the second part of the second case?
Sir, I'm Dr. Gayatri. I will
Okay,
take the
guys.
second part.
Okay, for the third case, who will be taking the third case? Anyone?
Please volunteer, specifically the people who have exams nearby.
Sir, I can even take the case third.
Is there any other person we give chance for other patient other person?
Okay, sir.
Yeah. Anyone? I think there are 15 participants. Anyone who going to take for going for the exam? Okay. I think we need two more candidates, right? Yeah. Anyone?
Dr. Abhijit, for the third. Dr. Abhijit Paul.
Hello.
Okay.
Yes.
For the
third Dr. Abhijit will volunteer, and we need one more.
One more.
Good evening, sir.
Hi.
Yes, good evening. Please state your name and.
Good evening, sir. I am Dr. Abhijit Pal.
Yeah. Hi, yeah, you will be taking the first part of the third case, and anyone second part? Okay. Then I shall open who are going to take the the last question. Open to all. Come on. Yeah. Okay. Anyone?
There are so many people. Please volunteer. Yeah. It is a friendly mock exam. It is not an exam. So
yeah.
We are revising. So please volunteer. Please be free and volunteer. This is not. Nobody is going to judge you. And if you make mistakes, this is internal only. This is not the real exam. And if you actually volunteer, then you will learn more. Please. There are many more people who have not volunteered, including Dr. Devi, Dr. Kakasan, Dr. Tonmoy, Dr. Rasmi.
Yes, sir.
Yes, doctor. What's your name?
Asma.
Okay.
Asma.
Okay.
Hi, Dr.
Okay.
Asma. Okay, so we got 6 candidates. Okay. When Dr. Kaushik, when you feel like I can start, you can let me know.
I think we can start. We can start. We have.
Okay. So all candidates mute and only the candidates that answering please unmute. Okay. Okay. Good evening. I'm Dr. Logan. Today I'm going to take a short mock on neuroophthalmology (VIVA). Okay. May I know the first candidate?
Yasmin.
Okay, Yasmin, are you ready?
Okay, ready.
You should say yes. I'm ready with confidence.
Yes, I'm ready.
Okay. We shall start. Okay. This is 25-year-old man. 5 days ago, he woke up with vision loss in his left eye. He denies eye pain or pain with eye movement. He has felt fatigued, tired, and developed a low-grade fever over the past few days. So, how you approach this gentleman?
Sir,
Dr. Logan,
it's
slide is not moving. Slide is not
visible.
moving.
Slide is not moving.
Yes, it's not visible. You can
Uh, how to, okay. You can't see my slide at all.
no. The slide is visible, but the next slide is not visible. Just click on the second slide, second page, like the case one page.
Oh, okay. Now, okay. Is it okay?
No, just click on the case one, like second page of the presentation.
Okay. Now I am clicking the second side. Okay.
But it's just unshare this and reshare again.
Okay.
Unshare this and reshare.
Let me see how to okay. Okay.
Screen is not visible to me.
Okay.
Yes, screen is not.
Yes, okay. Is it now?
No.
Okay. Come, let's for the how to, okay. Can you see? Okay, let me do like this, easier for you all. Do you see my screen now?
No. Just please unshare the screen first.
Okay.
Yes. Now again redo. Reshare.
Okay. Give me some time. I think I open too much. Okay. So now, okay. Okay, can you see my slide now?
Yes.
Now
Now it's
I can
all.
see.
Okay.
Okay.
Sorry for the trouble. Okay, let me tell again. Dear, okay, 25-year-old man, 5 days ago, he woke up with vision loss in his left eye. He denies eye pain or pain with eye movements. He has felt fatigued, tired, and developed a low-grade fever over the past few days. How you approach this gentleman?
Okay. He's 25 years old and he has a sudden drop of vision, right? Sudden drop of vision in only one eye, left eye, and there is no pain, and there is fatigue, tired, developed a low-grade fever. Okay, I will take detailed history about past medical history, any treatment he is taking, any medication he is receiving, and if he is immunocompromised or immunocompetent, then I will check for his eye, ocular, if there is any the visual acuity, onset, course, duration, and it is the first time or recurrent, if he had any attack before, and detailed systemic history, then I will proceed checking the visual acuity and pupil, color vision, and see the fundus and check the
No,
pupil.
before slit lamp examination, what else you wanted to do?
Um, I'm thinking if sudden unilateral loss of vision in young age, I'm thinking either it's a
No.
vascular
No, just your examination. You haven't complete your examination. What examination you would do?
examination, ocular examination.
Yeah.
I will
How you would approach before you want to examine this patient under slit lamp?
I will check the pupil and the visual acuity, color vision, and confrontation
Okay.
test.
What you want to check in the pupil?
I will check for anisocoria or positive relative afferent pupillary defect as he has unilateral sudden loss of vision.
Other than that,
Anisocoria, heterochromia, and the pupil, direct and indirect. Then I will check the visual acuity and color vision and confrontation test and to check the optic disc function.
no, other than one more, what else you could check?
Extraocular muscle motility.
Okay, fair enough. Okay, then after that, what you do?
The clamp examination, fundus examination to look to the optic disc and the macula.
Okay, fair enough. Okay, let me give you some details. Okay, so the vision is 6 on the right eye and counting finger on the left eye. Pupils are equal size. There is left RAPD. Color vision is 14/14 and the left eye is 0/14. And then ocular motility normal. Neurological examination is normal. Then slit lamp examination is normal. There is about half cells in the vitreous in the left eye. Okay?
Only cells in the vitreous in the
Yes, in
left
the
eye.
left eye. Okay. Now, you can see the slides, right?
No, but the scenario, there is scenario in my mind. I can check.
Okay,
Or should I see the
I
photo first?
simplified. Unfortunate, yeah. I don't know how it works, but you all not seeing my slides. Okay. Okay. Okay, I stop, pause, and then I resume again. Okay, I stop. I do not know how to solve this. Let me see first. Okay. How about if now I unshare my slides. Let me go. Okay. Can you see my slides now?
A
A
visual
bit smaller,
acuity,
right?
everything, yes.
Okay, but
Yeah.
it's okay. You can show all the details are there. Just that the slit lamp examination normal, there is about 0.5 cells in the vitreous in the left eye. Okay.
Okay, now from this examination, I can see
Okay.
there is a optic nerve.
No. This is the details I give you. Okay, can you see this slide?
Yeah, I can see.
Okay, can
in
you
the left.
describe this? What is this?
Okay, in the left eye, there is a optic disc
No.
blurred
What
edges.
is this actually? What is this picture?
Fundus photo, color fundus photo.
Okay.
Color
Describe.
fundus photo of the posterior segment. The left eye, in the left eye, I can see left disc blurred edges and the swelling and the hyperemic disc, little hyperemic, and tortuous blood vessels, and I can judge the macula. I feel there is maybe macular thickening. Maybe there is macular thickening, but the macular, yeah, maybe there is macular thickening.
Still not complete. What else you miss?
Blood vessel looks tortuous, and around the optic disc there is a edema also.
Fine. That what else you miss?
Blood vessels, optic disc, macula, and the other eye, right eye looks normal.
Okay. Normal means what? What do you mean by normal?
Normal means the right eye is well defined, pink in color, no blurred edges, blood vessel looks normal, not tortuous, not dilated, and the macular reflex looks normal.
Okay. Okay, maybe in future you can go more systematically. It's okay. We continue. Can you see can you see this picture? Can you see this picture?
OCT of both eyes in
Okay, please describe this.
Okay, in the left eye, the OCT is donating a paracentral neurosensory detachment, and only paracentral, and involving part from the macula, not all the macula, and there is very shallow also neurosensory detachment down. Just juxtafoveal, very shallow neurosensory detachment.
No, okay. What image is this?
This image is OCT macula.
Okay. What type of OCT macula is this? Is this OCT macula this image that you usually do in your practice?
No.
Okay. So what is this picture actually?
You mean the type of the OCT
Yeah.
spectral domain or enhanced depth?
What?
You mean the type of OCT enhanced depth OCT or spectral domain?
No, this image is what?
Raster photo.
Huh?
Raster photo?
No. How they get this image?
After dilatation.
Okay. Usually, what type of OCT that you always will do in your practice?
I'm not
You
working
wanted
in
to know
OCT.
what parameter you would normally do. You wanted to know in normal OCT.
Parameters measurement like for the macula or
yeah macular OCT. What parameters in usual practice you would like to know?
There is three and there's six and six, I think.
Okay, that are cubes. Okay, actually, what are the parameters you are looking in normal OCTs?
I'm looking in the OCT. I will look for from up to down to the vitreous to exclude any vitreous opacity. Then I will look
No. What are the parameters? The numbers in the normal OCT shows what?
Numbers of central macular thickness.
Yes, thickness, right? So in normally you look for thickness, correct? Right? How about in this OCT? What you are looking for?
In the left eye?
Yeah.
There is a significant increase in the thickness in the paracentral view, not in like just juxta to the fovea in the left eye.
Okay, fine. Okay, this is a cross section, you know. Okay, let's remove. Okay, what do you see in the left eye?
Increased macular thickness, increased paracentral macular thickness in the area between the optic disc and the macula.
Okay, so can you more clearly define what is this structure? Can you see my mouse?
This is edema. This is serous elevation.
What do you mean by serous elevation?
Intraretinal fluid.
Is it intraretinal?
Yes, between the RPE photoreceptor line and between the other layers of the retina. It's intraretinal.
Okay, let's okay, so what do you think this patient has?
Sorry, again?
What do you think this patient has?
Just 1 second.
I mean, from all your history, presentation, examination, and funders, and up to the OCT.
1 second.
So what do you think this
1 second,
patient
can
have?
you because the voice now I can't hear. Can you just
Can
1
you hear
second?
now?
The voice is...
Hello, can you hear now? Hello. Am I
Yes, 1
audible?
second.
Okay,
Yes,
can you
you
hear
are
me?
audible.
Yeah, okay. So
now
what
okay, I
is
can hear.
okay? So what you think this patient having? Okay, can
Hello?
you summarize this case?
Sorry, headphone is like not working, so
Okay. Okay. Can you tell what is the what you think this patient having? Can you hear me? Okay, I think we lost her. Maybe the second candidate. Can you continue from here?
Sir, so summarizing this case is a
Yeah.
24-year-old male with the acute loss of vision in one eye, unilateral loss of vision associated with the fatigue and with color vision defect and visual acuity counting fingers with the RAPD in the left eye and vitreous showing a few cells and clinically there is optic disc edema as well as macular edema. And it's a painless decrease in vision.
Yeah. So what do you think this patient having?
So neuroretinitis.
No. What do you think? Okay, if the patient having a relative afferent pupillary defect with the optic nerve function loss, so what is patient having actually? Okay.
With neuritis, they will be painful, usually pain.
Yeah.
And painless is usually
No. What do you think? What do you think? Let's think. You correct. You got the summary. What is patient actually having? Okay, let's not go for that. What inflammation of which part is having? Where's the inflammation?
optic nerve.
Okay, yeah. Patient having optic neuritis.
Yes,
okay. So what type of optic neuritis patient having? Okay, I ask you, how many types of optic neuritis you know?
Yes, sir. Neuroretinitis, retrobulbar neuritis, and papillitis.
Other classification more commonly we use. Do you know?
According to etiologically, can you define or divide optic neuritis? Classify.
Infective.
Okay, I think you should know. This patient having atypical optic neuritis. Do you agree or not?
Yes, sir.
So what it means by typical and atypical optic neuritis?
So in typical optic neuritis, usually it affects females. It would be a unilateral painful loss of vision. And usually there will be no involvement of the macula, and atypical usually can affect the males. It can be in older age group, it can be bilateral.
Okay, what are the definite criteria for typical optic neuritis? What it lead to?
Multiple sclerosis.
Okay, fine. Okay, fine. Okay,
multiple
that's what I
sclerosis
want.
can be an
Okay.
association.
Okay. So let me proceed with the case. Okay. About where is my can you see my screen now? Okay. About
Yes,
1 week later, these features develop. Can you describe this?
So this is a fundus photo of the left eye, which is showing a disc with irregular margin, blurred margin with hyperemia, and it's elevated. And The surrounding blood vessels of the disc are also hazy, they're not made out, and macula shows exudates in the form of a macular star. I mean,
So what is your most likely diagnosis?
neuroretinitis.
I mean, which eye?
Left eye.
Okay. So, what is these features actually?
Hard exudates.
Yeah, heart exudate, but do you know any name for it?
Macular star.
Huh? What is that?
Macular stars.
Okay, fine. Do you know how macular star develop?
At the area of the junction of the edematous and the normal retina.
Which layer?
In the Henle's layer, sir.
Okay. What is
outer
Henle's?
plexiform.
Okay, fine. Okay. Okay. Can you give me some causes for macular star?
Malignant hypertension.
Fine. Others?
Macular star related to tumors. Or
fine. Others?
The infective neuroretinitis.
Fine. At least one more if you can.
I mean, generally, even in diabetic retinopathy, we can have some hard exudates in the macula.
Well, oh, okay. Since you mentioned that, where is the what is the characteristic of the heart exudate in diabetic retinopathy?
In characteristic around the blood vessels.
Well,
not sure.
Okay. Okay, fine. So can you you give any other causes of macular star, you know? Okay, fine. We move on. Okay, since we know that so the diagnosis is neuroretinitis. Now, can you give some differential diagnosis for neuroretinitis?
So neuroretinitis can be caused by Lyme's disease,
Is Lyme disease very frequent in your country?
No, sir.
Where is it Lyme disease more common?
South America.
Where?
Africa.
Africa?
Not sure, sir.
Then why you come with the first disease as a Lyme disease? Come, let's how you want to do differential diagnosis for neuroretinitis?
The infective causes are
Okay, first is infective, fine. Second?
Inflammation.
Okay, fine. Okay, so infectious, what can you name some of the causes for infectious that can cause neuroretinitis?
Tuberculosis, syphilis.
One more?
Toxo.
Okay, fine, good. Okay, how about non-infectious causes?
Sarcoidosis.
Okay, fine, that's enough. Okay, so what are the most common cause of infectious neuroretinitis?
Tuberculosis.
Well, I'm not sure. You are from India?
Yes, sir.
But I'm not sure. But in generally, what are the most common cause of infectious neuroretinitis?
Not sure, sir.
Okay, fine. Okay, can anyone answer this question?
Sir,
Sir,
most
syphilis and
common
cat
is
scratch disease.
cat
One
scratch.
person, please. Who's going to answer?
Bartonella henseli.
Syphilis and cat scratch disease, sir.
Who's there?
Dr. Faiza.
Okay, Faiza. Okay. Okay, Dr. Faiza, what are the most common cause? One cause.
Syphilis,
I'm
infectious.
not, Dr. Kaushik, is syphilis and tuberculosis very common in India? I think maybe Dr.
Yes,
Kaushik is
it's
not.
common, but I don't think
Okay.
neuroretinitis will be like the first cause will be TB or syphilis. What
Yeah.
would be the typical cause
Bartonella
for
henseli.
neuroretinitis?
Sir,
Yes,
most
Okay.
common
yes,
will be cat scratch disease.
Okay.
yes.
Bartonella
Who's
Most
henseli.
common
okay?
will be cat scratch. So cat scratch will be
Cat,
the
Okay.
first differential disease. So
yes,
Okay.
60%
should
cat
not
scratch.
mention
Okay.
you should not mention lying, etc. Because
Okay.
the examiner will catch you there.
Okay. So I agree. So who just now said that cat
Sir,
scratch
Dr.
disease?
Abhijit, sir.
Okay, Abhijit. Okay. Can you tell me what causes cat scratch disease?
Sir, Bartonella henseli.
Okay, can you roughly simply tell me about this organism?
So it occurs after scratch of cat and followed by low-grade fever.
Okay, no,
And
clinic. I mean, what type of organism is it? Is it virus, parasite? What is it? Bartonella henseli.
it's Bartonella hensels. It's sir hensels bacteria.
Okay, what type of bacteria?
Uh, intracellular.
Fine. I mean, okay, fine. You can't guess that. Okay. If you
Yeah,
say you
sure.
don't know, you just tell don't know. Okay. Do
Yes,
you
sir.
know
I don't know, sir.
how this disease is transmitted?
Through direct contact, sir.
What type of contact?
Scratch.
Okay. Fine. Okay. So how we wanted to test for this disease? You have a patient here with neuroretinitis, and we found that you have some history with the cat scratch, and you wanted to find whether the patient develop cat scratch disease. So what are the tests that you do?
The taste first. The taste.
Laboratory
Sir,
tests. Yeah. What type of test you can do?
sir, I'm not sure, but I may I try.
Yeah. Try.
Sir, IgG and IgM antibody
Okay,
against.
fine. Okay. Result of serological test, Bartonella enzale, IgM is negative, IgG titer is 1 to 4096 is high. So what do you think actually?
Sir, it's what I say. It's a chronic thing. IgG. It's an sir acute disease. Acute for IgG. It's an acutely happen.
So what do you think of this?
So I think it is due to it's a cat scratch disease that IgG has been raised too high.
So why you think the IgG is high?
Uh, sir, I can't get the
You
question.
need to know this, okay, because these are the common things that you can do. Okay, let's move on. What are the yes, okay. What are the treatment that you can give for this patient? No, we stop first. We go back to the first candidate because you fair for them. Who's the second candidate?
Yes, sir. Akshay.
Yeah, okay. Yeah, you are the okay. What treatment you can give for this patient? You are having a patient with neuroretinitis. So you know the cause is cat scratch disease. So what are you going to do?
So IV antibiotic and
What?
steroid.
Okay. I mean, anyone?
So, adding antibiotic, and as there is inflammation, vitreous cell, we can.
We need to go. What are the? I mean, okay, and what?
Doxycycline.
No. That's all. Yes, you can give. But what are the standard way of managing cat scratch neuroretinitis?
Sir, in antibiotic, we can give
No,
ciprofloxacin.
no. Before the
Sir,
antibiotic,
we
what are
can,
the studies shows?
Okay.
sir, in this we can give intravitreal steroids.
No, don't go for that. No, what are the studies? Basically, what is the textbook classic said about cat scratch neuroretinitis?
Self-limited?
Yes, that's the term that I want. Okay, mostly will be self-limited. Means
Limited.
what?
It will resolve spontaneously by 4 to 6 weeks.
Okay, then, but however, there are some regime of treatment. Maybe you can read about that. Okay, we move on to the second case. Okay, or what are the who's going to volunteer for this case?
Sir, may I ask one thing, that what the
No,
question?
we proceed with the case first. Okay.
Okay.
Okay. So who's going to volunteer for the second case?
Sir, I will, Dr. Faiza.
Faiza, okay. Are you ready?
Yes, sir.
Okay. 35-year-old white woman, 6 days ago, she started to notice double vision with objects separated horizontally. The double vision is worse when looking to the right and improved when looking to the left or when reading. The double vision persisted. How you approach this patient, Faiza?
Okay, sir. So I will take a brief history from the patient regarding any history of any headache, associated headache, any tinnitus or vertigo, or any history of any trauma. And other than that, any medication she's been taking, and since how long is this diplopia occurring, and is it associated with any pain? Other than that, I would also ask about any refractive glasses that she's been wearing, or any okay, any glasses she's been wearing, and
now you know that the patient have double vision. What are the first question you want to ask the patient?
is it persistent? And
generally when you see in the clinic, patient having double vision, what you would ask the patient first?
Sir, diplopia, whether it's horizontal or vertical, for near or far?
No, not that. That's all later you can ask. What are the first thing you want to know whether when the patient have double vision?
Uniocular or monocular?
Yeah, that's the common thing, right?
Yes, and binocular.
Because it's help you a lot, differential diagnosis. Okay?
Yes, sir.
Okay. Let's we move on. Okay. You still haven't approached the okay, how you approach this case now?
Okay, so I'll ask about that, whether the diplopia is monocular, binocular, vertical, or horizontal. Then I would assess the patient's visual acuity, refractive error, if present any. Then I will do the extraocular movements. On doing that, I'll check if there is, ask about any pain and diplopia worsening on which case, and it's improving on which case, as the patient told us. And
what other examination you want to do?
Other than that, sir, I would like to do the optic nerve functions like pupillary examination, color contrast, and confrontation, and then I'll go for a slit lamp examination.
Before slit lamp, what you want to do?
Sir, pupillary examination. And
no, generally you want to know when patient have their double vision. What common simple things that you can do, systemic examination in your clinic?
Sir, systemic, not ocular.
No, systemic, basic general examination. What do you would like to know?
Pulse, blood pressure, and
yeah, common, right? The blood pressure
deficits.
You want to know, right?
Yes,
yeah, okay,
pulse.
let's give you the thing. The blood pressure is 121/82. heart rate 74, visual acuity is 20/20, pupil equal, there's no RAPT, color vision is normal, visual field which you miss is also normal, neurological examination which you miss also normal. Okay, slit lamp examination are normal. Before that, I want to ask what year I mean neurological examination. What neurological examination you would do
There's
for this patient?
cerebellar examination and other hemiplegic.
That's not the way to answer. Why you want to go for cerebral only? Then you won't go for any cortex examinations in the brain. I mean, what common neurological examination you would do?
Sir, any cortical examination for any like limitation of movement?
No. I mean, neurological examination, basic examination that you would do is to check what?
Sir, for reflexes?
No. I mean, the basic one, simple one that you know this, sure. What you would test when you want to check for neurological examination?
For hemiplegia or hemiparesis, sir?
No. Basic neurological examination. You've been doing it since undergrad and before your other, I mean, specialty and everything. What are the common neurological examination you would do? Come, anyone can help?
The patient is conscious, oriented.
No. I mean, basic examination you can
The
do in your
tone
clinic.
and power of the patient.
No. That's not. Yes, that's what who said cranial nerve.
Okay, sir. Yeah.
You should do cranial nerve exam. That's the basic examination. How many cranial nerve are there?
12, sir.
Okay, at least you know that. Okay, come, let's proceed. Okay, so please describe this.
Okay, sir. So this patient is orthophoric in the primary gaze. In the right, in dextro version, there is limitation of abduction in the right eye. While in the levo version, there is full movements and no limitation in any eye. There is no elevation deficit. In the dextro elevation, there is a mild limitation of in the dextro elevation in the right eye. While in levo elevation, there is no any limitation of movements. In the depression is normal, and there is no limitation in levo depression, but there is depression limited dextro depression in the right eye.
Okay. How about the picture down there?
Okay, so this is a colored fundus photograph of right eye and left eye, and in the right eye there appears to be a cupping of 0.3 with healthy neuroretinal rim with well delineated margins. The vessels appear arising from.
Okay, so what you see in the fundus?
It's normal fundus
Okay,
photograph.
fine. So based on this extraocular movement, what you think your conclusion for this extraocular movement?
And why is the fundus given, doctor? Can you say why did they put the fundus photo also with the ocular motility images?
So there is
What is
no
the
any
significance
parallel,
of this?
no any
Yes.
cortical lesion.
No. Why did they show the fundus image with the specific movement defect? What is the role of fundus in here? Okay, please continue. Please continue.
Yeah.
Any optic nerve, like
Optic nerve what?
papilledema to rule out false localizing sign.
Yes.
So what are
Please
your
continue.
conclusion for your extraocular movement? Even in your examination, after you complete your extraocular movement, you should give a summary, short summary, what you find.
Okay.
So you examine this patient, what you find your summary.
So there is a right abduction deficit in the right eye that is present also in the dextro depression and dextro elevation.
Okay, fine. It's good, but one term before the abduction deficit on the right eye. What type of abduction deficit is this?
Sir, the parameter you're asking about plus 4 plus 3, that you're asking?
No worry about parameter. That's not important. But okay, when they pay, what type of strabismus you know?
Sir, concomitant.
Okay, what else?
Okay.
They are one. What are they?
Sir,
yes.
They ask about
According to the muscle function. Yes, muscle function. According to the muscle function, what would be the diagnosis of this? This is concomitant, and what is the other name? What caused this incompetence? Due to?
Due to the diseases, like you're asking myasthenia, thyroid.
No.
No,
It's okay.
no.
Yeah. Okay.
Muscle, strength of muscle or paralysis or something. What should be the thing? What is it called? Squint. Is it? Please continue.
Okay. So, okay, you tell about incomitant. What are the difference? How you want to know whether the patient having incomitant squint or comitant squint?
That if there is equal to 5, angle of deviation is 5 and is equal in all quadrants.
Okay, fine. That's okay. So in this patient, what type of strabismus patient having?
It is non-comitant, sir.
Okay, so it is how you complete finding?
So this is a non-competent abduction deficit, non-competent type of strabismus in the right eye.
I mean, it's incomitant, correct, right?
Yes.
Okay, incomitant. What type of movement that affected? Abduction, right?
Yes, abduction, right, sir.
So what if there is an abduction deficit? What is the name for that tropia?
Sir, there is no tropia in the primary case, but there is abduction deficit only in the right eye.
So this might be very subtle also. Very subtle also. It might be more prominent in the distance. So just tell like what is the diagnosis? You have seen the images. You have gotten the clinical scenario. What is the diagnosis here?
So it looks like myasthenia gravis to me.
Oh my God! No, why you come like this? So myasthenia. Okay. Okay, fine. Okay, this is okay. Okay, that's why don't jump into the diagnosis. What? Okay, you see there. Okay, now which eye is affected?
Right eye, sir.
Fine. Okay. What type of squint that the patient having?
Sir, non-comitant strabismus.
Okay, incomitant. Okay, incomitant. Yes. Strabismus of the right eye. Okay, fine. So, okay, fine. So, fundus is normal. Okay, now can you give a differential diagnosis for this patient?
Okay, thyroid eye disease and myasthenia gravis. And
what is the age according to the age?
35 years.
Like, and you have been shown a fundus photo. Now, why did they show the fundus photo here?
Because
so
no any fundus pathology.
Like which fundus pathology do you suspect in this case? What, like there is only abduction deficit, no, in the right eye.
Yes, sir.
So if I ask which muscle can be involved here, so what would be the answer?
The sixth nerve.
Yes. So why did they give the fundus photo?
To fundus photo to rule out any that I mentioned that false localizing sign, the papilla edema.
Yes. So basically go logically. If you say thyroid eye disease, so does the patient look like he is having thyroid eye disease?
No.
And also, what is the age of this? And if you say myasthenia gravis, are there any signs of myasthenia here? So just please use your logic. There is a fundus photo given, and they are showing this. So do not hurry. There is no hurry. Just use your all the logic, and then only tell the differentials, which would be in most common should be first, and then you will say the rarer things.
Right, sir.
And also this if it is thyroid eye disease, the lateral rectus is
the
last involved. Okay, so you cannot say this is lateral because this can come as the last difference here. So
Yes,
these are
sir.
very common. You have to use your logic. Do not say like rare things, and they will, the examiner will catch you there. Please continue.
Right.
Okay. So now, okay, you know already. Okay, so what can you tell about this case actually? What is your impression of this case? Patient having?
Sixth nerve palsy.
Yeah, that's it. Okay, which side is sixth nerve palsy?
The right sixth nerve palsy.
Yeah, that's likely. Okay. So
Okay.
now I want to ask you how you want to differentiate whether this patient having restriction of the muscle, or is it due to the nerve?
Sir, on examination, I would like to do the adductions. I would cover one eye and then check for if there is any movement, or if there is any paralytic or restrictive. That's how I'll differentiate. Other than that, I can go for saccades also during examination.
No,
And
no,
then
no,
I
no.
would,
Let's we talk about the common tests that you would like
sir,
to know whether what are
force
the
duction
tests?
test, sir.
Okay,
Force
what is
duction
force
test.
duction test?
Sir, basically, force duction test is a test that we perform in the OT under topical anesthesia, where we differentiate between restrictive and paralytic. What we do, we hold the affected muscle from the limbus, and then we move it in the direction of the muscle. So if there is any restriction, the muscle will not move in that direction. But if there is paralysis, the muscle will move in that direction.
Okay, fine. Okay, so after finding all these things, what you will do for this patient?
Sir, after finding all of this, then I will counsel the patient. I would, since she's a young female, 35-year-old, I would also carry on underlying investigations, and an MRI also I would like to do to rule out any pathology underlying, and then I will go for my management. Initially, I would just give
Okay,
her.
wait. So what is in this case, what is the most important investigation you would like to know?
Sir, cranial MRI imaging.
Okay, fine. So this is the MRI that you do. Okay, what you find here?
Okay, sir.
First, tell the full form of player. What is this player?
Sir, player, sir, sorry, sir, I don't know.
And what are the dots showing? What are the dots? This white dot, etc. There are red dot, blue dot, and white dot. They are showing something. What are they showing?
Contrast, sir.
No. In both contrast and flare, there are this arrows. No. Why have they shown the arrows? So you can.
The hypo or hyper intensities, sir.
Yes, in flare, you can see some, like there are white lesions. No, they are
Yes, sir.
showing this which are
plaques,
near the ventricles.
Sir,
Which
they
are
could be
near the
plaques.
ventricles. Yes, what could be the, like what are you seeing here?
Sir, demyelinating plaques.
Okay,
Dr. Logan.
so how you will manage this patient?
Sir, initially
okay, can you summarize this case?
Sir, initially she has a complaint of diplopia is a major complaint.
Okay.
That also in the right lateral position. So I would like to counsel her, and then I would, since and her vision and all her examinations are normal, so I would ask her about patching. I would advise her for patching, and I would also give her base in prisms for diplopia, so that I will check when I will counsel the patient to follow up, and then even after 1 to 2 months, if it's not improving, then I can go for botulinum toxin injection.
No,
in the.
This is a great line. You could not pass this case 100%. What you should do for this patient? This is serious. What you should do for this patient? Can anyone?
Sir,
Sir,
Basically,
basically,
Well,
the
one
patient.
person, please. Who's going to answer? Please tell the
Sir,
name.
may I, Dr. Gayatri?
Okay,
Sir,
what you are
basically
going to do?
Sir, this patient is a female patient, 35-year-old. I would like to do the MRI, and after confirming no any compressive lesion, I will go for a
now why you now what you are
MRI is
saying?
done. No,
Okay.
MRI
Yes,
is done. Why do you want to do it again? Just see MRI and say
sir.
what is your plan.
What you want to do now?
So
MRI is there already.
Yes.
Okay, what you want to do now?
Sir, I want to do lumbar puncture to rule out, see the pressure of
This
a patient.
is another grave mistake. Are you a ophthalmologist or are you a medical specialist?
Ophthalmologist, sir.
So, okay, I mean,
Refer to neuron.
what you want to do?
Sir, we will refer this patient to the neurologist.
Fine, that's all. Okay. Those who did not tell this 100% couldn't pass. What do you think, Dr. Kaushik?
I think it's always better to tell you do not refer. You say I'll collaborate with neurologists to manage this case because there are neurological involvements and there I can see some but certain brain lesions here.
Yeah.
So it is always good to and this case needs collaboration. This is for sure.
Yes.
And do not say I'll do lumbar puncture.
No.
So you are not trained in that. If you say, then it is a negative point. It can fail you.
And then how can you just leave the patient with patching, prism, and you want to do a squint surgery? This is impossible. You can't do this. Okay? It's okay. Don't do this. Okay? Just you need to refer to neurologist. This. Okay?
Yes. Okay. Sir.
Fine. Okay. Come next candidate.
Sir, I'm the next.
If immediate like treatment is needed, what can be given? Like if they want some immediate relief.
Sir, we the neural basically if the pressure is this, then we can give the neurologist will give him the tablet acetazolamide.
No. What is the image showing? Look, you have to use your brain. Why I said now there are some changes near the ventricles. What does that tell you? There are changes and
the patient should take steroid.
Paraventricular demyelinating lesion.
Yes, most likely these are called Dawson fingers. Dr. Logan, am I correct? Hello.
Yeah.
Basically, these are demyelinating.
Yeah.
I'll request one candidate to please take a screenshot of this and then discuss this thing in detail and also the details of the sequence in the group. Please continue.
Okay. So now the thing is, okay, who's the next candidate going to answer the question?
Sir, I'm Dr. Gayatri.
You are the next one for this case. Okay. Fine. So this lady, we found this and you refer to neurologist already. Okay. Then this patient, then after a while you notice that the patient having these features. Can you describe this?
This is okay. This is the photo of the face, which is showing the both eyes. There is the anisocoria. Left pupil is larger than the right pupil.
Okay, fine. So what you will do?
So so basically this is I would like to check for the pupillary. I would like to do the pupillary examination of this patient.
Okay, continue.
I will do like the pupil examine direct and check the isocoria in a dim and a light. Then I will look for the extraocular muscles and the pupillary examination and color vision, visual fields and contrast, sensitivity, visual acuity.
Okay. So what do you think this patient having?
And I will do the extraocular muscles of this patient too, to see if there any restriction or something.
This is the same patient but it's okay, fine. But let's see that what from this picture, what you think this patient may have?
So the one things which is the patient having something marks on this, like the patient went for some surgery or the post-op surgery.
Fine. Okay. So now you feel that the patient having anisocoria, correct, right?
Yes.
Okay. If the patient having anisocoria, how you would approach this patient?
So anisocoria, I will check the anisocoria in the dim and the light.
Okay, good. Okay, what will happen?
To check the whether it is not reacting or increasing in the size in the dim and light. To differentiate it, the cause of anisocoria.
Okay, when you off the light.
Yes.
Okay, so what you look for?
When I dim the light, I will look for if there is any construction on the pupil or if it's not, if it's in the
okay,
same
let's
side.
we say that when you dim the light, the anisocoria increases.
anisocoria increases.
Yes. So what are the causes?
And then it could be anisocoria increases in the dim light. So people's.
So if this happens, anisocoria increases in light, which eye is abnormal?
Dr. Kaushik, you already helped them a lot with this question.
No. So can you please repeat the question? And
If the anisocoria increases in light, which eye is abnormal? There are two eyes, no, right and left. If you see that in light the anisocoria increases, then which eye would be abnormal?
if anisocoria increases, the light may constrict. So the one is if the left eye is not constricting in the light, so means the anisoc and the right will the constrict.
No, just answer the simple question. Don't. This is very what they call. It's already give you the answer actually. Okay. Don't confuse yourself. Okay, let's find. We move on. Just that you need to find. Okay, let's say that this patient having Horner syndrome. Okay, what are the features of Horner syndrome?
So in a Horner syndrome, there will be a meiosis, and ptosis, mild ptosis, and anhidrosis.
Okay. So in this patient, if it's a Horner syndrome, which eye is the Horner syndrome, right or left?
Right one, because this is the small people as compared to the left.
Okay. So in the Horner syndrome, what you can do?
So we will check the anisocoria, which will be the worst in the dim light.
No. We forgot. We already passed the exam, all the exam and everything. Okay, we come with the Horner syndrome. What you can do?
So we will go for the pharmacological investigation of a patient to rule out the Horner syndrome.
Okay, not to rule out, to find whether the patient having Horner syndrome or not. Okay, so how you want to find whether the patient having Horner syndrome or not?
So we will do the test with the this apraclodine 1%. And
okay, so what you do? Okay, what it will do?
It will dilate the Horner pupil. Apraclodine will dilate the Horner pupil.
Okay, if you don't have apraclonidine, what you can do?
We can use the cocaine 4%.
What it will do?
It will dilate the normal pupil. It will not dilate because it's increased potentiate the release of acetylcholine.
Fine. So all these tests will show you whether the patient have Horner syndrome or not.
Yes.
Correct? Okay.
Yes.
So Horner syndrome, can you differentiate which level the lesion is in Horner syndrome?
It's the pre or post ganglionic lesion. Even we can do with this a pharmacological test. Or
what test?
The pharmacological we can use the phenylephrine to 1%, or we can use this.
No. Okay, if you want to use phenylephrine 1%, what it will do?
Phenyl will dilate the post-ganglionic Horner.
Fine. Okay. If you don't have phenylephrine, what other things you can use?
We can use the adrenaline or amphetamine, hydroxyamphetamine.
Okay. So what it will do?
The hydroxyl will dilate the pre-ganglionic or the normal people.
Okay, fine. Okay. So, okay. Based on this, and this is based on this case, okay, the patient having a limited right eye movement, which we conclude as a sixth nerve palsy, and then you find a lesion in the brain, and then the patient developed the Horner syndrome. Okay.
Yes.
So why you think this lesion could be?
If this could be a lesion in the post-ganglionic, it's involving due to the cavernous sinus involvement on due to that or due to the
where you think the lesion could be?
It could be lesion could be in the brain. This will be the post-ganglionic. If the patient having LR6 palsy.
Well, this is a bit tricky question. It's okay. We move on. Okay. The answer is in the cavernous sinus. Okay, never
Yes, sir.
mind. It's not
Cavernous
that
sinus.
the thing. Okay, let's go for the last case. Who will be volunteer for this case? Short case actually.
Ayun, sir.
Okay, yes. Okay. Are you ready?
Sir. Yes, sir, I'm ready.
Okay. This is 55-year-old man, father with glaucoma, treated with topical medications. He went to see an optometrist for a routine examination and was found to have optic nerve cupping in both eyes. His intraocular pressure was 20 on the right eye and 21 on the left eye, and his central cornea thickness was 550 micron on the right eye and 546 micron on the left eye. Okay, so what do you think of this case?
This family history of glaucoma,
Okay.
55-year-old, optic nerve, cupping. Sir, cupping is not mentioned how much.
Yeah, it's okay. It's okay. There is a cupping. Okay. So
Session.
what you think about this intraocular pressure?
So it is in the
Is it
upper
high
range.
or is it normal?
Sir, it is I am seeing the corneal thickness. It's like within the normal range or rather
Okay,
little bit
fine,
higher.
fine, fine,
So
fine. Okay.
it
So
is
let's move on. Okay. Okay.
intraocular pressure is normal, sir.
Okay.
As
So okay,
considering,
how you approach this patient?
sir, I will like to examine the patient from beginning, like taking the visual acuity and uh, no, okay, fine. Then I will assess the optic nerve function, like doing the examining the people that direct, indirect, reflex, RAPD, color test,
Okay.
field test. Then I will go for anterior segment examination and posterior
Fine,
segment
fine. Okay.
examination.
Let's we say that the blood pressure all normal, visual acuity is good, and your pupil is equal. There's no relative apparent pupillary repair, color vision, ocular movement, slit lamp is normal. All the neurological examination is normal. Okay.
Yes, sir.
Okay. So what can you describe this?
Yes, the left side showing the color fundus photo, limited color fundus photo of right eye and left eye. I am describing the right eye. The right eye, there is the presence. There is presence of vertical Kapdix ratio is around 0.8 with bipolar thinning and the pale neuroretinal rim and the yes and the rest of the part the vessels are
Okay, fine,
normal.
fine. So
And the
what you
left
see from the fundus, what you can conclude?
sir, there is uh, presence of sir to to tell my diagnosis I want to see
No,
the
not diagnosis. I mean, just conclude. Conclude only. What is your conclusion from the fundus?
fundus, there is uh, this pale neuroderm. So there's optic neuropathy. Uh,
Don't give diagnosis. Just now you
okay,
are
sir.
fine until you give a diagnosis, then it will be wrong. So what you see actually?
I'm seeing uh, increased Kapdix ratio and pale
Okay, fine,
neuroderm.
fine. There's a very severe increased Kapdis ratio, correct, right?
Yeah.
Okay, what other things you find?
I find the neurodeltoid rim is pale.
Okay, which eye?
Sir, I am finding, sir, it's both eye, left eye more might be. I am finding both eye, sir.
Okay, fine. Okay. I want to see. Do you see any optic nerve pits or not?
Yes, I just want to.
Do you see there's optic disc pit?
Sir, in my screen, I am seeing mobile. apparently might be in the left eye. It's not.
Do you think that the patient having optic nerve pits?
So I'm not confirmed in this screen.
Okay.
Now, is optic disc pit bilateral or unilateral, Dr. Abhijit? Usually, optic disc pit is bilateral or unilateral?
It might be present unilateral. It is unilateral.
No, in this patient, do you think that the patient have optic nerve pit or not?
Sir,
No,
I think
simple. You need to say yes or no. That's it. Yes
no,
or
sir.
no? Huh?
No, sir.
Okay.
In my screen, I am not seeing, sir.
Okay. Okay, fine. If you say no, no. Okay. Fine. Okay. How about another picture on the right
Yes,
side?
sir.
What is it?
Yes, it is the visual field test of right and left eye. I mean, enlarging. The right side is of right eye, and the left is left eye, and they're showing. I'm just telling the summary of that. Actually, the
Can. Yeah. Okay, just tell the
yeah,
summary.
yeah. There is presence of in the left eye. There is presence of superior scotoma. It's not arcuate, superior scotoma, and which is respecting the vertical line. Not okay, and the left eye.
Dr. Abhijit. Okay, continue.
Yeah.
Please continue.
Hello. Yeah. And seeing the left eye, there is the visual field defect. Apparently, the defect is showing that the defect is respecting vertical line, not the horizontal line.
Okay. Come, let me see this. Do you see any acute defects or not?
What, sir? Sorry?
Acute defect.
Arcuate, yeah, in the right eye, I have arcuate. It should start from the optic disc.
Do you see yes or no?
No, sir.
Do you see sacrocentral scotoma?
Yes, centrocecal. Yes, sir. I'm seeing centrocecal scotoma.
Okay.
What is centrocecal scotoma?
Okay.
What is centrocecal scotoma?
The scotoma, which involves the central paracentral area of the visual field.
What is centrocecal, then paracentrocecal would be the actual term. No.
The sound is breaking. Am I audible, sir? Hello.
Yes.
Yeah.
Okay, come, let's see first. Okay, this is not sacrocentral central scotoma, okay?
Okay.
Okay, so basically, you try to conclude. Can you give a summary of this case? What really happening to this patient?
Yes, I want to keep.
Okay.
Sir, I want to the 55-year-old man with the family history of glaucoma presented with vision. What do you say? I have forgotten, sir.
Okay,
With
so what you find
normal.
in the, what is the optic disc cupping and then the visual field? So what you think?
Sir, I think the defect is showing it's like not respecting the horizontal meridian, it's respecting vertical meridian. I have to evaluate the patient neurologically. As in clinical, I am saying the pallor in the neurolateral rim and the visual field defect in HFA, it's respecting the vertical line.
Yeah, so what type of visual field defect is that? What do you mean by respecting vertical line?
Yeah, it's superior apparently superior quadrantopia.
But I saw
It,
there's an
by
inferior also got a lesion. Why you
yes,
say there's a superior?
it's not, sir. Sorry, one minute. Just let me think once. It is not superior. It's
Superior
the
or not?
left.
I could see superior also.
Yes, superior, and the right eye has superior and is only superior, and the left eye has superior inferior. But it's
Okay.
bitemporal fashion.
Are you sure or not it's a bitemporal?
So I'm just trying to fix my comment.
So you sure or not it's a bitemporal or not? Bitemporal hemianopia.
Yes, sir. It is. I think it's bitemporal.
Why
It's
you
not.
think it's a bitemporal?
Sir, it might be. It's not full bitemporal. It is that. It involves a sector that
Okay, fine. So what you want to do for this patient?
I want to evaluate neurologically. I want to do neuroimaging like MRI of brain.
Okay, fine. Okay.
Which area do you want to see? Which area do you want to see, Dr. Abhijit? Which area?
I want to see the paracellular, the pituitary region, around the pituitary region. The
Okay.
focus.
Who's the last candidate just now?
I am
Yes,
Dr.
sir.
Ovi, sir.
Oh, you are the last candidate, right?
Yes, sir.
After this, there's no more. Anyone want to extra candidate?
Yeah, sir,
Yes,
I
sir.
can.
Okay, who
I
are
can.
you?
I'm
Huh?
I'm Satish.
Okay, Satish. Okay, come, let's proceed. Okay, so in this case, what you would do?
I would image the patient.
Okay, let's you say that you image the patient. Let me see. Okay, what is this?
So this is an MRI image.
Why you say this MRI? Why not CT scan?
The bone window doesn't appear as hyper.
Fine. Okay. So what type of MRI is this?
I think it is a contrast MRI. MRI with contrast.
Okay, so what you see?
I'm seeing a mass lesion.
Where is this mass lesion?
It is in the paracellular region, in the pituitary area.
Okay, so if you think that there's a lesion in the pituitary area there, where is the compression would happen?
It will compress the optic chiasma.
Okay, when
from
there
below.
is a compression of optic chiasm, what type of visual field defect you would see?
And which
So it
side
would
is involved more, Dr. Satish? In the image, which side is involved more?
Yeah, in this, it is involving one side more.
Which side?
Probably, it's the left side. Left side
Basically, it is
involving more.
pressing from below, pressing the chiasma from below, and from the left side more. No?
Yes.
Okay, please continue.
So it would depend upon whether the chiasm is prefixed, postfixed, or centrally fixed.
I mean,
And
commonly, what type of visual field defect you would see?
You will get a bitemporal field defect.
Fine. Okay. So what you do for this patient?
Dr. Satish, if it is bitemporal field defect, which side would be deeper? Superior would be deeper field defect, or inferior would be deeper field defect? In such
The
case.
superior would be deeper.
Yes. Okay, please continue.
Okay, so
what do you do for this patient?
I will check the hormone levels of these patients.
What hormone you want to check?
I want to check the growth hormone, thyroid hormones.
Why you want to check hormones?
To see which type of pituitary tumor it could be and whether I can have medical management to shrink the tumor.
How you would shrink the tumor by medical management? What type of medication you want to use for medical decompression of the tumor?
So if it is a growth hormone secreting tumor, then I don't remember. I can't remember which is the drug you would give. Bromocriptine works.
Are you sure? What is when you use bromocriptine?
Bromocriptine.
Okay, fine.
I'm
Dr.
not sure.
Satish,
I'm
I'm just playing with you. You can't do this because you answered quite okay, but then you're doing this, you can't pass. What you think this patient? The patient is what this case, you think this case is what you think of this case? What I mean, what do you think
with a
of this
patient
case?
which you want to collaborate, and how would you plan? Like, you may not be able to manage the patient yourself, you know.
I would involve. Yeah, I would involve an endocrinologist.
No,
in
Dr.
my
Satish,
management.
like this, simple as this. This case, what type of a pituitary tumor is this?
This is a fairly big pituitary tumor that is
What
now
type? What
compressing
type? I
the
know it's
chiasma.
big. So what type?
Type, I'm not sure. So are you asking acidophilic,
No,
basophilic?
simple.
According to size, do you have any
size? It
classification?
is a it is a macroadenoma.
Okay, it's an adenoma. Okay, if patient having like this, is it what do you think of this case?
So this is a pituitary tumor that needs management to take care of the compressive effects on the
Okay,
optic
so
chiasma.
in what type of treatment this patient need?
So
okay, first of all, you just need to know this case is what type of case is it? Is it the case that you can just sit around, give an appointment in 3 weeks time or 4 weeks time? What is this actually?
No. Yeah, there
what
is
case
both
is this?
surgical and medical, but
no. Just before that, what case you think this case is?
It is a pituitary macroadenoma.
Yeah, I know, but what will, okay, come, I simplify for you. Okay, what will happen to the patient if if the patient didn't receive any treatment?
A patient will lose vision.
Well, what do you think is more important than vision? Dr. Kaushik, I think you should you should take over.
Patient can lose life
Dr.
or
Satish,
raised
like this,
infection.
you see, if you see a patient like this in your practice, patient having a brain tumor, correct, right? This is a very emergency, life-saving, life-threatening condition. So first thing that you should know is you should take this case very seriously, the way you answer, okay? You should show that you care for the patient. You want to do something very urgently. You want to, you want to refer to a neurosurgeon. Let the neurosurgeon manage this patient. Okay, how you want to refer to endocrinologist? Maybe I'm wrong, but I never seen any endocrinologist managing this patient. So this is something should know when there's a tumor in the brain, you need to urgently, you need to show that this is emergency.
An urgent.
Okay?
Okay, sir.
Okay, that's all. Okay, Dr. Kaushik.
Sir,
Yeah. That's all I got that case, only this case only.
the first 1 and 2 case, some questions.
Yeah, short questions, yeah.
So it's not been answered by us. The
Yeah, you
first,
should find the question. Yeah, you should find the answer, because I think if I give the answer, then it would be not active learning. Maybe in the group you can discuss about the cases. Okay.
okay, sir. Sir, please
Okay.
post the
Okay.
case then in the group.
Okay. Okay. Okay.
Okay, sir.
Okay, Dr. Kasik, can we end now?
Yes, sir.
Okay.
Thank you. Thank you.
Okay. Thank you. Thank you, Doctor. Okay. Thank you very much. Okay. Good luck for your exam.
Thank you, sir.
Thank you,
Okay.
sir.
Okay.
Thank you,
Okay.
sir.
Okay. Bye.
Thank you.
Bye. 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 Bye.